The same with any treatment that we give systemically to patients. There are a proportion of people who will be resistant to that therapy. And that resistance will either be primary resistance or acquired resistance, or a combination of both. So we know from all the clinical trials that we've done, and there are now numerous trials in lung cancer, that literally there's a proportion of patients who just do not benefit from therapy. So trying to figure out why that is and who these patients are, how we can identify these patients, has been really the core part of a lot of people's research in recent years. So I think one of the issues that's very clear now is that if you're not very fit, if your performance status, as we call it, is 2, which means you're needing a bit of help, maybe having showers and that kind of stuff, you need a bit of help shopping, whatever, but still fairly mobile. So you're still out of the chair, still chatting to people, still doing most normal activities. Those patients just don't do well with immune therapy. If you've got, what you may have heard at the meeting here, a high neutrophil to lymphocyte ratio, neutrophils are involved in chronic inflammation, those patients don't do well. If they've got a raised LDH in the blood, they don't tend to do as well. And you can make a score called a Lippi score, which allows you to kind of stratify patients. And those with high scores do badly, and those with low scores do well. So that's important. And we also know that when you look at phase 2 trials, you get one trial that might have a 40% response rate, one might have a 19% response rate, for example, in the neoadjuvant setting for patients who've got potentially resectable disease. And that probably has something to do with the burden, the volume of the disease that's present. So they're simple things you can use to identify the patients. And then obviously if the patient's tumours respond and then grow, or whatever it is, like they're acquiring resistance, or they grow because at first line, and you're watching those tumours very carefully and scanning and symptoms, then that tells you those patients are now becoming resistant anyway. To me, the extraordinary thing about immune therapy is that it works. I think, I was involved in doing immune modulation type studies for many years, and when the checkpoint inhibitor study emerged, suddenly it was a bit of genius by the people who thought of it, say, oh, if you block that interaction between those proteins, you're going to do well. And now we have patients, allowing for what I've said, if they've got, for example, high PD-L1 expression and they're treatment naive, they can get a single drug and they've got about a 40% chance of being alive in 5 years' time. That's pretty cool. That's a lot of our patients. So big strides forward. So what I was doing today in my lecture on Wednesday was I was looking through the literature. I had the very challenging talk of going through all that literature. There's literally thousands of papers come out about how we might make our immune therapies work better, on the one hand, and how we might identify new ways, new approaches to immunotherapy in the future. And so a lot of the trials that are being designed are looking at, can we add drugs to the immune therapy to make it work better, like anti-angiogenic agents? Can we look at other checkpoints in the immune cascade, the immune talk, and target them and make them work better? And maybe they work on their own, and then they work better if added to the existing checkpoint inhibitors. And can we just look at something completely novel, which I think I refer in the lecture to this as developmental versus disruptive research. The developmental research is where you take an existing treatment and you add things to it and try and make it work better. And that's always the most common, in some ways the most easy thing to do. And then the disruptive is actually coming up with a completely brand new idea and saying, is something very simple going to work better? Akin to what happened with the initial checkpoint inhibitors, which were true disruptive research by the people who got the Nobel Prize for the work. So, and to me, there are some disruptive things coming through that are really, really interesting, and perhaps the most interesting one is this MR1 protein that presents completely novel antigens. And these antigens are really cool because what makes them beautiful is that when you're talking about normal antigen presentation by cancer cells, it's polymorphic. HLA systems are vary from person to person. The proteins that are presented by each individual person are very different based on what your HLA is like. But this is the same for every patient. The MR1 presentation machinery is monomorphic. It's the same for every single person. Very, very little variation. And it presents these cancer-specific metabolites. So, and they're unlikely to change very much because they're being made by enzymes. So it's an enzymatic process making these. So they're not quite sure yet what these metabolites are, but they're not proteins as would be the normal case. And an even more exciting aspect of this was the fact that the receptor that identifies these, the T cell receptor identifies these, is also monomorphic. So technically, we could take, for example, and again, it's an area I'm learning a bit about, you could transfect white cells from any person with this receptor, and if they've got a cancer, no matter what type of cancer it is, and you put those cells back in, potentially it could attack those cancers selectively and doesn't damage normal cells. This is amazing. If this is true, there'll be lots of things to overcome. I think one of the points that was made by James Spicer was that you're still going to have the microenvironment playing a role in trying to suppress these cells getting in, but it could be a big breakthrough. It could be a big step forward. So it's very exciting times, I think.